brain oxygenation, then later on pupillometry.
Thank you, Jan. Thank you, Stephen. Good morning, everyone. Twice this session and then 2 other times during the day. So we'll have 15 minutes after the following one, so I have to rush. The question is brain tissue oxygen better than ICP? And my answer will be that it's complementary rather than better. An important issue is that hypoxia, even irrespective of ischemia, is frequently observed in patients this study after traumatic brain injury. I will discuss predominantly about severe TBI patients and poor grade subarachnoid hemorrhage patients. That's where the majority of the data in terms of monitoring brain tissue oxygen are available. If you want to take all the studies we performed a systematic review with Julian Böse during the MMN consensus conference, all data available. There are actually quite a lot of studies, again predominantly in TBI and SAH, describing the utility or potential utility of brain oxygen. You have described the normal values. As for the pathological values, there is some debate as to whether it's below 20, below 15. Probably in between 15 and 20, this is the window of danger, but I think it's also very important to follow the trends of these values over time. Now, brain tissue oxygen, before describing the potential utility and superiority, is a complex variable that, if we want to summarize based on two, I think, very influential papers by Rosenthal and Manley, the UCSF group in San Francisco, and the group of David Menon, is influenced or determined by several additional variables. So it can be a surrogate for CBF, but is highly influenced, of course, by systemic oxygenation. Is also highly influenced, that's the way we test whether the monitor functions or not, by increasing the FiO2. So systemic oxygenation is a point. If you have lung injury, if you have hypoxemia, brain tissue oxygen goes down. Can be influenced by oxygen transport and hemoglobin, so you can slightly increase brain oxygen by giving transfusions. And this is what David Menon and his group described, there are barriers to oxygen diffusion, so you can have reduced brain tissue oxygen because you have edema, especially edema around the probe. And even if you increase or you try to improve brain oxygen, this doesn't work. And we see often patients in these situations, especially in the very early phase. The question always is pay attention not only whether the monitor functions by raising FiO2 shortly, but whether it is well inside. This is a big model, it's a recent paper. Pay attention, they put 4 probes. So you have a contusion in red, then you have the proximal contusion probe and the distal and contralateral probe. And what you see is that if your monitor is inside a contusion or too close to a contusion, then you don't see any changes to when you modify FiO2 and when you do hyperventilation. But actually the contralateral and the distal brain oxygen functions very well. There may be some difference in the absolute values, but if a monitor is ipsilateral but distant or contralateral, that's where you want to, when then it becomes useful. Now, having said that, the question about the superiority of brain oxygen. We did a proof of concept study in severe TBI patients, predominantly with diffuse injury. So what you see on the left-hand side is the brain tissue oxygen monitor together with ICP, and also there was a microdialysis probe. On the right-hand side, measure of CBF, notwithstanding the limitations with the CT perfusion, and describing thresholds of oligemia, so let's call it cerebral hypoperfusion, based on neuroradiologist assessments. And the question was then, if you only have ICP, which you see here in clear gray, well, ICP is quite good in detecting hypoperfusion. You see the area under the curve. But if you add on top of ICP, you have both monitors. Brain oxygen and ICP is this dark gray. And then the third one is the 3, ICP, brain oxygen, microdialysis. You are better. And this difference in the ROC area on 30 patients is significant. So yes, it's better. And the reason why is that you combine, so you have a whole assessment of brain circulation, you have the pressure, but you also have potentially the flow. And so you can optimize, as is shown here, cerebral perfusion pressure. So you can test the system by raising blood pressure when a patient is hypoxic. And in some conditions, in some patients, this will allow you to optimize brain tissue oxygen. This has been shown both in TBI and SIH. I often show this study because this is one of the studies that also changed our practice of avoiding hypervolemia and actually raising blood pressure. So we moved from Triple H to induced hypertension alone, because the only H here, induced hypertension alone, improves brain oxygen. It also improved in the study regional CBF measured by Hemedex. Whilst this was not the case with hypervolemia hemodilution, that actually, by reducing hemoglobin, had a negative effect on brain tissue oxygen. So you see that with this monitor, actually, you also changed practice. And another important point, and we have now data on 200 patients, and we recently again looked at the association during the early phase in patients with severe TBI and intracranial hypertension, 70%. There is a strong association between hypoxic episodes and the burden of hypoxia and functional outcome, which is not actually the case with ICP, which is associated with mortality. This has been shown by Chang. We also show it when I was in Philadelphia. The fact that if you have a combination of elevated ICP with brain hypoxia, this is what changes the outcome. And when you, notwithstanding a limitation, when you do a multivariable model, you enter the severity of the injury, the admission Glasgow, the severity of systemic injury, and you enter brain hypoxia, the duration, intracranial hypertension, the duration. You see that brain hypoxia stays in the model. It's a very strong, actually, outcome variable, more, let's say, more than ICP. And recently, the Manley group very recently showed that the proportion of PO2 values below 19, so they find out this new threshold, so it's in between 15 and 20, below 20, you see that especially in the first 2-3 days, hypoxia is something that you see when you monitor it. And so you can potentially improve hypoxia and maybe have an impact on outcome. They describe the same associations between hypoxic episodes and outcome. Now the question is, if I have a brain oxygen based management versus ICP alone, does this change the outcome? Now there are two systematic reviews based on made by the same group, by Peter Leroux group in Philadelphia, and the problem is that you know this is not really high-level evidence. It's retrospective analysis. Some use outcome, others use mortality. In these 4 studies, there seemed to be a better outcome based on the brain oxygen-based care versus the standard ICP-CPP-based care. But I went through all the studies when we did these consensus in Philadelphia, and pay attention to 2 studies, Martini and Fletcher. And what you see is that it depends how you treat brain oxygen. If you provide too much fluid and vasopressors because you want to improve brain oxygen, then you pay the price, because extra fluids, as in the general ICU, is not necessarily a good thing, it's actually a bad thing. And if you raise too much, you use too much vasopressors, this can also be an issue. So the problem is what you do, as always with monitors, with the variable you monitor. How do you treat these patients? And this can be actually quite challenging. And if you see this publication, it's the PO2, so the randomized control trial, and there will be a larger trial. So this was designed to sort of proving that you can improve brain oxygen by having intervention. So they did this in 10 ICUs in the US, 120 severe TBI patients. Now, the protocol for brain tissue oxygen treatment is a nightmare. When you take this publication, you look at how it was designed to improve brain oxygen, it's very complex. So it's something that must be, if you introduce it at the bedside, really try and be simple, because there are multiple interventions and it can become quite complicated. But they were able to, based on this protocol, reduce the burden of hypoxia, while ICP control was similar, interestingly. So you can reduce hypoxia and maybe you can improve outcome. There was a trend, only a trend. So that's probably the reason why recent papers, large reviews on traumatic brain injury recommend brain tissue oxygen probe, as you see here. The same in subarachnoid hemorrhage. You see that in high-risk patients in this review, they recommend the fact of using brain tissue oxygen monitor to manage these patients. The Intensive Care Medicine Society, I was quite pleased to see strategies incorporating brain oxygen together with ICP may improve outcomes, so it's a hot topic. The problem is how to integrate these variables. So this is what we do at our center. We regularly monitor ICP and brain oxygen. We regularly monitor transcranial Doppler for compliance. And this is how we use it. So we use brain oxygen to titrate CPP in combination with Doppler. We don't use the PRX. And we also use it to avoid too much hyperventilation and potential secondary ischemia. So the combination of these three. And this is my last slide, is the simple way we treat brain hypoxia at our center. So first ICP, then we do a trial by raising miniature pressure. We always check the lung and use protective ventilation, and only in some circumstances we transfuse if hemoglobin is below 9. Thank you very much.